Good morning, my friends. Well, as we have been seeing and we have been hearing that stenting or in other words, treatment of the left main coronary artery stenosis has always been a challenge. Challenge because if you create any complications, it is going to be a life-threatening complications and you may lose a patient on the table, which is not acceptable in the present era. Over and above that, if you come across a patient who has got left main stenosis or left main occlusion and is presenting to you STEMI, that becomes still a bigger challenge. So my job is to highlight some of the features of a left main bifurcation treatment in a patient who presents with acute myocardial infarction. Well, if you go by incidence, involvement of the left main coronary artery, both in terms of stenosis and occlusion in STEMI is very infrequent, 4 to 7% of the cases. But once it occurs, particularly acute occlusion, the mortality is very high and they often present with sudden cardiac death or out of hospital cardiac arrest. Well, ECG often shows anterolateral MI, and so therefore it is not very, it is often missed. The diagnosis of left main occlusion is often missed on the ECG. You go by it is anterior wall myocardial infarction, and the diagnosis comes only on angiography. But suspicion can come if the patient shows presence of ST segment depression in more than 1 millimeter in 8 or more leads, or if there is a ST elevation in AVR. So you can start suspecting left main occlusion. They often present with hypotension, cardiogenic shock, malignant ventricular arrhythmias, cardiac arrests. And the management is, of course, immediate medical stabilization, supportive therapy by means of intubation, ventilation, giving them a respiratory care, and then emergency revascularization, whether it's primary PCI or CABG. Primary PCI is certainly a preferred modality of treatment, particularly in situations like acute occlusion with TIMI flow less than 3, presence of cardiogenic shock, life-threatening cardiac arrhythmias, coexisting comorbidities where surgery takes a high chunk of mortality, availability of on-site interventional cardiologists and anesthetists. That's the most important factor because you cannot afford to lose time, and you need to have an experienced operator who has been performing left main PCI at least 20 to 25 per year. Now, this is our experience or my experience. We have done 613 patients by 2020. This does not include the data of last 1.5 years. And if you look at the type of intervention, 95% had elective intervention, but 5.3%, 33 out of these patients underwent an emergency intervention for left main coronary artery disease. And out of these 33, 14 were STEMI. 16 were non-STEMI and 3 were iatrogenic dissections. So almost 4% of our population consisted of left main intervention due to STEMI. In these 14 patients, the presentation was hypotension in 8, out of which only 1 died. 3 patients presented with cardiogenic shock, 1 died, 2 died and only 1 survived. Cardiac arrest, 2 patients came with cardiac arrest and both died. Patients with normal blood pressure, there was only 1 case survived, and overall 14 patients, the mortality was 35%. Now let me show you some interesting cases. This is the first case which we saw in 2006. This is an extensive anterior wall MI with hypotension and came to us with malignant ventricular arrhythmias. This is a young man, 45 years, came in 2010. He had previously a stenting of the proximal LED in 2006, that means 4 years prior to his present presentation. He stopped all his medication for 3 weeks and he presented with anterior wall MI, blood pressure of 70, ejection fraction 35%. When the patient was shifted to the coronary care unit, he immediately developed ventricular tachycardia, was cardioverted, put on ventilator support, shifted to the cath lab. Fortunately, the lab was available with a blood pressure of 50 to 60 millimeters on inotropic support and tachycardia with a heart rate of 140. And this was his angiogram. You can see here that there is a total occlusion of the left main and there is a stent which is lying in the LED. Well, what we did was the First thing was there is a thrombotic occlusion which we analyzed and we start giving him Apiximab. There was some for a second issue whether we should put him on IIBP or not, but we thought we should first start poking the left main and start restore the flow. So we put a guide wire was placed in the circumflex. It went, on its own it went into circumflex. We did some thrombosuction in the from left main, and single pass led to restoration of flow in the circumflex. You can see TIMI3 flow in the circumflex and TIMI1 flow in the LED. So following this, we deployed a stent DES in the circumflex ostium. Why? Because after 5 minutes, the circumflex again started occluding and the patient BP again fell down. So we thought we should first take care of the circumflex. So we deployed a stent in the circumflex, which looked reasonably okay, and by now the BP had stabilized. So it gave us some breathing time to now poke into the LED. So we could manipulate the wire into the LED, and this is the result after deployment of a second DES from LMCA to LED, overlapping the LCX stent, and then we did a kissing balloon dilatation. So restoration of TIMI3 flow was obtained. This is the final result. The patient was uneventful after being taken out of the cath lab. He was extubated after 48 hours. Hemodynamically, he was stable for the next 2 days, discharged on day 5, and follow-up angiogram after 4 weeks. This was the follow-up angiogram after 4 weeks, showed that both the vessels were very patent. The patient was on follow-up for almost 6 years after that, and he was doing very well. This is a second case, again a left main bifurcation stenting, but not a total occlusion, presented with anterior wall MI with hypotension. 52 years old young man, ejection fraction 30%. You can see here that left main has got a distal stenosis. There is a total occlusion of the LED, and LCX has got a significant stenosis at its origin, and then there is a disease at the origin of the obtuse marginal branch. So since the patient was becoming hypotensive, so immediately we passed 2 wires, and having done that, we used the SKS technique. This was again very, I think in almost about 2009 or 10. So we used SKS technique, which was very popular at that time. 2 stents were taken down, both inflated at the same time, and the result was excellent. This is the final result. So again, this patient did very well and was discharged on day 4. The third patient is a patient who presented with acute posterolateral MI. Now, where we were a little baffled by the angiogram. This patient was 63 years with acute chest pain, was stable, hemodynamically he was stable with a blood pressure 110. He had only ST elevation lead 1 AVL V5 V6, so we thought he may be having only circumflex stenosis, but this was his angiogram. Now, you can see that left main distally is having mild disease, but LED osteoproximal is a very moderate disease, but the tightest stenosis is in the original circumflex and the obtuse marginal branch. So we first did a stenting of the LCX. You can see from the ostium, a stent was placed with wiring of all the 3 major branches, and then following this, we stented the obtuse marginal branch going from the stent in the circumflex using the tap technique, and then followed up by a kissing balloon dilatation. Following this, we did the stenting of the LED from left main to LED using a reverse T technique, and then this is the final result. So here we had a trifurcation stenting in a patient with acute posterolateral MI. And lastly, a patient who came with cardiogenic shock. This is a young man, was having chest pain for the last about 8 to 10 hours, came to us with a blood pressure 70, oxygen saturation 77, ECG showed anterior wall MI with bifascicular block with ST elevation in lead AVR, ejection fraction of only 20%. The patient was very sick, inotropes were started, intubated, pharmacotherapy was started, and high risk consent was obtained, IABP was placed in the lab. So this was his angiogram. Right coronary artery was okay, young man, but you can see that there is a ruptured plaque with a thrombus in the left main with some flow in the maintained in the circ OM, but LED is 100% occluded. We had we did not lose any time in cannulating this LED, but since we were very concerned about this OM also, because if we lose this OM, the patient would die on the table. So we did a mini crusher. I took 2 stents, one in the LED, left main to LED, and the other one was in the circumflex origin. and then did a kissing balloon inflation. All this with a blood pressure of 80-90 and augmented pressure about 120 on IABP. So TME 2 plus flow could be restored, but unfortunately the patient was stable, conscious on day 2 with a augmented pressure of 135. ECG showed a partial resolution of ST segment. Day 3, patient developed high-grade fever, no urine output, blood biochemistry showed parameters suggestive of septicemia, and the patient expired with multi-organ failure. So, friends, what is the role of IABP? Arbitrary, ambiguous, and controversial. ACG-AHA say it's a class 1 indication, particularly if a patient is in cardiogenic shock and unresponsive to pharmacotherapy. And a meta-analysis of 16 studies have shown that there is a significant reduction in mortality. There is no significant benefit if cardiogenic shock has been pre-existing for more than 12 hours with oliguria. Now, this is another study of 30-day all-cause mortality, which is an average of 13 studies. You can see here the difference between patients who come with cardiogenic shock compared to those who do not have cardiogenic shock. The overall mortality at 30 days is 5 times higher in patients who present with cardiogenic shock secondary to left main occlusion and anterior wall myocardial infarction, and this figure is statistically significant, 10% versus 56%. And another study which shows a long-term outcome for unprotected LMCA when they compare it with non-LMCA shock. So you see that in hospital mortality is again much higher in patients who got a LMCA as the cause of cardiogenic shock, and this is statistically significant as compared to non-LMCA. 30-day outcome, 1-year outcome, and long-term outcomes are all inferior in patients who have got a shock secondary to isolated LMCA occlusion compared to those who do not have LMCA occlusion. So in conclusion, what is the take-home message? Hemodynamic and electrical instability are the most important challenges in such cases. A speedy action is the most crucial factor in preventing sudden collapse. Cases like these must be done with on-site support of anesthetists. IABP must be inserted if required. Strategy of stenting should be decided only after establishing the flow in both the vessels. Liberal use of GP2B3A, which of course may not be required in the present era because of highly potent antiplatelets of agent being available. PCI strategy to be kept as simple as possible. Bifurcation may require a 2-stent strategy, and do not hesitate to use a 2-stent strategy. Rotablation may be required rarely in such cases. With that, I thank you very much.